So I am Dr. Diva Boone from the Southwest Parathyroid Center in Phoenix, Arizona. Glad to see people from all over. So now we have Texas, St. Louis, Washington, Illinois, Oklahoma, Tennessee. Excellent. All right. So if you have any questions during this, please post the comment or post the question in the comments. I don't see the responses right away because there's a bit of a delay, a bit of a lag when I'm doing these videos. So I won't see any response right away. It'll be just like a minute delay. Okay, so do that if you have any questions. We will get started. So this is the parathyroid education course. I did a bunch of these videos about 2 years ago and would try to do it monthly, did a bunch of topics. Unfortunately, Facebook decided that they were not going to save all the Facebook lives anymore. So those videos all got deleted, unfortunately, which was very upsetting. But it is time to redo this course and redo these videos. And so this time I will be recording them and then saving them and then putting them on YouTube, so you'll be able to access them forever, hopefully. Okay, so with this course, I want to cover pretty much everything. But for right now, we're going to start with the basics. So I didn't put the syllabus online yet because it's not finalized. But for this live, Facebook Live right now, just to go over the basics. I know that a lot of people on here, I do recognize your names. I know a lot of people on here already know a lot about parathyroid disease. So this is going to be, this is going to be review for a lot of people. But I do need to cover it, and I think it's important to cover these basics just so that we are all on the same page. A lot of the things that come up even after surgery can sort of be explained by the basics of parathyroid disease and what the parathyroids do. So let's jump into it. So the parathyroid glands, you've got 4 of them. A lot of people don't know about them until they have a problem with them. But most of the time, for most people, these glands are working hard all the time and they are functioning normally. And I want to go over what that normal function is, what it looks like. So I presumably have normal parathyroid glands. And how do I know that? Well, I've never seen my parathyroid glands and I hope to never see them. But I know they're functioning because I just had my labs done recently and my calcium level was 9.5, which is perfect. So that tells me, okay, my calcium level is 9.5. What does that mean? Well, that means that my parathyroid glands are doing their job. My body, and like every other human body, wants to have a calcium level that's in the normal range, typically somewhere in the 9s for adults. And the parathyroid glands have one role, which is to do that, keep the calcium level in that range, typically somewhere in the 9s. So if I know my calcium is normal, I can guess I've got functioning parathyroid glands. All right. Why is calcium so important? So if you think about it, it's kind of crazy that we have these glands, this organ that's dedicated to regulating calcium. That is really all it does. When you think about other organs, you have your kidneys that regulate a lot of different electrolytes and minerals. But we've got these tiny glands that just regulate calcium. That's it. Which means that calcium must be really important because you wouldn't have organs that dedicated to dealing with it unless it was very important. And calcium is really important. Now, when I ask people, what is calcium important for? Well, any child can tell you that calcium is important for your bones. And that is 100% true. Your bones would not have the strength. They would not be able to, hold you up if you didn't have calcium. That is the main place that we store calcium in our body. Most of the calcium that you've got is going to be in your bones. So that's true. The strength and the structure of bones is very, very important on calcium. But your parathyroid glands, and this is pretty important. Your parathyroid glands do not care about your bone calcium. They don't care. They have no way directly of measuring it. What they do is measure the blood calcium level. So parathyroid glands, again, you've got 4 of them. They exist solely to regulate your blood calcium level. Calcium we know is important for bones, but why do we have something that regulates the blood calcium? And we have that because the blood calcium level is actually really important for a bunch of different things. So your nervous system depends on it. So nerve signaling, when your brain is talking to the rest of your body or to your muscle, or even the signaling in the heart, all of that depends on calcium levels and calcium channels. Cell signaling, so when cells talk to each other in the body to make processes work, that relies on calcium. Even blood clotting. So your blood clotting actually depends on calcium as well. Calcium was known as clotting factor 4 until we figured out what clotting factor 4 was. And now we just call it calcium because it is. But it's an important clotting factor in your blood. Okay. So it's necessary for all of these things, necessarily for cell function, for your brain function, your muscle. Your heart really relies on that for proper signaling, meaning proper, when your heart is beating, basically it's an electrical signal that's going through, like, to cause it to contract. That all relies on calcium. So calcium's super important for all of these things. That's why your parathyroid glands are regulating it. It's not really regulating bone calcium. Again, parathyroid glands don't see the bone calcium. All they can see is the calcium level in your blood, because the blood is flowing through the parathyroid glands and they can sense that and they can move. Then they can do their thing. But they don't care about bone calcium. They care about blood calcium. Okay, so now you understand the importance of the blood calcium levels. Really important for functioning throughout your body, especially nervous system and blood clotting and muscle function. Okay, so what happens normally? Well, normally your parathyroid glands are continually sensing calcium levels. This is the best metaphor for this is the thermostat in your home. So say you're in the winter, say it's very cold, and you set your thermostat to 68 degrees, okay? Thermostat senses that. As the temperature drops below that, it senses that drop, and then it turns on the heating to bring the temperature back up, okay? As the temperature goes above that, then it senses that, okay, we've gone a little too far, and it cuts out, stops the heating so that the temperature can gradually drop back down to where you want it to be. And it does this throughout the day. So the thermostat's continually sensing the temperature and regulating whether or not the heater is on. That's the parathyroid glands. So they are continually monitoring your calcium levels in your blood, and they are determining what to do based on that. Now, what do parathyroid glands do? There's only one thing they can do, which makes our life really easy. So the only thing they can do is make parathyroid hormone. That's what they do. They can either make more parathyroid hormone or they can make less parathyroid hormone. They really don't have any other decisions to make. It's, should I make more parathyroid hormone or should I make less? So think about it. Now your calcium is going in your blood, it's going into the parathyroid glands. They're sensing that calcium level. Well, what happens when the calcium level is too low? So the parathyroid gland has in its mind this set point for where it wants calcium to be, and now it's too low. Well, it turns on. It says, okay, we got to make more parathyroid hormone. That parathyroid hormone then goes throughout the body to various sites to raise the blood calcium level. Okay? Now, if the calcium level now is too high, the parathyroid glands sense that. Again, they only have one decision, which is make more parathyroid hormone or make less parathyroid hormone. Well, if the calcium's too high, they make less. That's their decision. It's like turning off the heat, right? If it's 90 degrees in the winter, it's a little too hot in your home, the thermostat is going to sense that, the heating is going to switch off. That's what should happen in a normal situation in parathyroid glands. So normally this is happening on a micro level throughout the day. Your calcium level's dropping, your parathyroid glands will make more hormone, the calcium level rises, maybe it goes too high, and then they make less hormone to let it drop down. All right? So think about it like a thermostat. This will explain a lot of parathyroid function. So when it'll help you understand the disease states, so primary hyperparathyroidism and secondary hyperparathyroidism, you really have to understand that basic relationship between calcium and parathyroid hormone and what happens in a normal situation. So normal situation, you can have PTH levels, so parathyroid hormone is PTH. You can have PTH levels varying throughout the day. That's okay because your parathyroid glands are doing that in order to regulate the calcium. So some days they may need to make a little more PTH to bring the calcium up, and some days they may need to make less. And there is a range where they can be kind of normal. When we check parathyroid hormone, if you're somebody who generally has enough calcium in your diet, and you don't have any issues with absorption, you don't have any problems with that, then typically your calcium level is going to stay in the normal range, and your PTH level is also going to stay usually in the low normal to kind of normal range. But when there are problems with the system, like with calcium, you're going to see changes in that PTH. And we will get to that in the next video when we talk about what problems can occur with the parathyroids. So right now it's just kind of normal functioning. Okay, so an important point about normal functioning. So I just gave an overview of the parathyroid glands, but what is normal? What are we talking about? It's all very abstract. What is a normal calcium level? Well, the first answer is it's not what it says on your labs. So I got my labs drawn recently, as I said, and I checked my calcium, obviously, because I'm a parathyroid surgeon. That's the first thing I check. But I check my calcium, and I also check what range it says. And when you get back your labs, there is a range of normal, right? For every lab, if you go to the right, you'll see what range we're looking for, what we want it to be within. And for a lot of these labs, those ranges are pretty good. They're pretty accurate. For calcium, for some reason, they are not very accurate. They usually go too low and too high. So it'll say often that a calcium of 8.8 to 10.3 is normal. That is not exactly true. An 8.8 is not normal for anyone. A 10.3 could be normal if I were 20 years old, but I'm not. So at my age, once you're in your 40s or higher, really your calcium levels should be in the 9s, and they really shouldn't go below the low 9s. So for most people, a normal is going to be between about 9.3 to 9.9 or even 10.0, but not above that. Okay, so that's what we're talking about with normal. That's where your body wants it to be. And remember, calcium is really important. It's so important, it has its own organ to regulate it. Okay? So it's not like some of these other things where it can be a little bit out of range. It's not really a problem. With calcium, when it's out of range, it is typically a problem because your body really carefully measures and calibrates and tries to regulate calcium levels. So, and it doesn't do that for a lot of other things, but when you have one organ that's dedicated to it, the body wants to keep it in a tight range. And that's true, that's calcium. So mid to high 9s is really where we want our calcium level to be. And when it's outside that, that's when our parathyroid glands have to make these decisions a little bit more often about whether or not they make more or make less hormone. All right. Okay. So that is the normal function of the parathyroid. Again, just to review, parathyroid glands regulate calcium. They are the simplest endocrine organs by far because that's all they do. They regulate calcium, and they do that by making one hormone called parathyroid hormone. The only decision they have to make day in, day out is, do I make less hormone or do I make more hormone? Okay? Calcium is low, I make more hormone. Calcium is high, I make less hormone. That's it. Now, why does that work? So I said that making more PTH or making more hormone would raise your calcium, but why is that? Well, parathyroid hormone does a few things throughout the body. Now, it may do more than these, but there's three main things that it does. One is it goes to your bones and it releases calcium from the bones. So this is how you get bone breakdown once you have a high PTH over time, because that parathyroid hormone, that PTH, is continually going to the bones and telling it to release calcium. So that raises your blood calcium. It's a quick way of raising it, but at the expense of your bones. And this gets back to what I said in the beginning, that your parathyroid glands do not care about your bone calcium. They will eat away at your bones forever if they have to in order to maintain the blood calcium level. Okay, that's very important. They don't care about your bones. They just care about the blood calcium. So that's the first thing it does. And that's one of the big ones. It goes to the bones and it releases calcium from the bones because that's the major storage place. The other thing that PTH does, one of the big ones, is it goes to the kidneys and it activates vitamin D. So vitamin D exists in several forms in our body, and I will have a whole talk just on vitamin D because it's a favorite topic of mine and of many people. So I'll talk about vitamin D at some point, but just for the basics right now, vitamin D exists in multiple forms of your body. There are multiple inactive forms, and then there's the active form. And the active form, it's called the active form because that's the one that's actually doing something. What it's doing is going to your intestine and increasing the resorption of calcium. So increasing that absorption in the intestines of calcium. If you're getting calcium in your diet, you're going to be absorbing it. Vitamin D is just going to help that along so you absorb more of it. So that's one of the main roles for vitamin D. So PTH is actually stimulating the conversion of the inactive form to the active form so that active form can then increase the absorption of calcium. So that's the second way that PTH is increasing your calcium levels. It's saying first it's taking calcium out of the bones, then it's going to the kidneys and saying, okay, let's activate this vitamin D. The vitamin D can go to the intestines and you'll absorb more calcium from your diet. And the final thing that it does is that PTH actually works in the kidney to stop the kidneys from releasing calcium. So in your urine's, your body, your kidneys are filtering out your blood all day long. And during that, they're releasing some of these electrolytes into the urine. Now, there's a normal amount of urinary calcium that most people will pee out every day. But if your parathyroid glands know that they need to increase the calcium, the PTH goes to the kidneys and it stops that release of urinary calcium. So it holds on to urine calcium, and so it can go back into the blood again and raise the blood. Those are the three things that PTH does, okay? 1, goes to the bones to release calcium. 2, activates vitamin D. It doesn't activate it directly. It stimulates that enzyme that activates it, but we'll just call it activates vitamin D. Activates vitamin D, which causes the intestine to absorb more calcium. And 3, it stops the kidneys from releasing too much calcium into the urine. So it tells the kidneys to hold on to calcium. Those are the 3 main things it does. And by doing that, pretty quickly, it can bring up the calcium level. All right. And then when the calcium level goes too high and it stops making PTH, it's the opposite. So you have less PTH, you have less conversion of vitamin D, you have less release of calcium from the bones, and your kidneys are allowed to pour out as much calcium as they need to. All right. So that's what happens in a normal situation. Again, we're just dealing with the normal right now, which is you've got parathyroid glands. They are healthy, they're functioning, and what they're doing all the time is trying to regulate your calcium, keep your calcium in a normal range. Okay. So that's the basics of what parathyroid glands do. Again, you have 4 of them. They're a little bit weird in that they are highly variable in where they are. So most of the organs in your body are in a pretty standard place, right? The heart is pretty much always here and your lungs are here. Your thyroid's right here. Your parathyroid glands are weird because while they're usually in the right place, they can be a little bit off. And they're pretty tiny. So they're normally about the size of a grain of rice or a little bit bigger than that. And they can vary anywhere from right under the jaw to down in the chest, almost to where the heart is. The reason they can do that is that before you're born, actually when you're an embryo, your parathyroid glands start up near the mouth and then they migrate down during development. And sometimes they get caught up here and they don't go far enough. And sometimes they go too far because they hang out with the thymus and they end up down in the chest. By the time you're born, your parathyroid glands are where they're going to be. And if they're normal, then we don't ever really care if you have a parathyroid gland in your chest. It's really just if you develop a problem later on and we need to find that gland, then we have to think about where it might be. But you could be sitting here with a parathyroid gland that is next to your heart, and as long as it's functioning normally, it doesn't matter. We don't care. It'll be able to do its job. So all it really needs to do is sense the calcium in the blood and make more parathyroid hormone. Okay. So I'll answer a question. So Susan asked, if the PTH activates vitamin D, why doesn't the inactive vitamin D raise? So that is important. When it's like any reaction in chemistry, right? When you have two reactants and then you end up with something else, you're decreasing whatever things you're using. So when your parathyroid glands are activating vitamin D, they are stimulating the conversion of the inactive form, which is 25-hydroxy, to the active form, which is 1,25-dihydroxy. What that means is you actually see a drop in the inactive form and a rise in the active form when parathyroid hormone stimulates that enzyme, right? Because the inactive form gets used up in the production of the active hormone. So if you're thinking about parathyroid disease, and I will get to this because this is a very, very confusing part of the diagnosis that often confuses patients and doctors, they see that low vitamin D. The reason that vitamin D is low with primary hyperparathyroidism is that the PTH is converting that inactive form to the active form. So if you have a lot of PTH, a lot of parathyroid hormone, your parathyroid glands are, making a lot of PTH, that is going to stimulate that conversion, which increases that active form, but decreases that inactive form. And we measure, for the most part, the inactive form. When you go to the doctor and they check your vitamin D levels, in nearly all cases, unless you really specify which one to get, they're going to check the inactive form, the 25-hydroxy, or it'll be 25-OH. That's the one we check, because in most cases, that level is very accurate for your long-term vitamin D stores. So that form lasts longer in the body and doesn't break down very quickly. So it gives you a good sense of how you're doing long-term with your vitamin D status. The only time that inactive form is not really accurate is in a couple of cases, the big one being primary hyperparathyroidism, because in that case, you are using up that inactive form and you have a high active form but a low inactive form. So it doesn't really give the full picture to just check the inactive. All right. That's very confusing to doctors because they don't remember that conversion part of PTH, but that's why you get a low vitamin D when you have parathyroid disease, when you have too much parathyroid hormone being made. Okay, so that's, again, the basics. What is parathyroid disease? So this is starting to get into the next video, but I'll just cover kind of the intro. When there's a problem with calcium, that is the biggest sign that there is a problem with the parathyroid glands. So as I said, parathyroid glands exist to do one thing. If that one thing is messed up, then usually it's because there's an issue with parathyroids, with a couple of exceptions. So if you see on your labs a calcium level, and by the way, calcium is checked pretty routinely on most labs. If you get a basic metabolic panel or a comprehensive metabolic panel, it is usually on there. So if you've gotten labs, if you've gotten any sort of annual primary care labs done at any point, it usually is going to include calcium. So you should be able to check your calcium levels and make sure they're in the normal range. Calcium levels that are outside the normal range are going to indicate a problem. When you look at your calcium, if the calcium level is a little too high, that in most cases represents a problem with the parathyroid glands. If your calcium level is too low, that is usually not a problem with the parathyroids. It might be, but more often it's a problem with you getting enough calcium or metabolizing that calcium appropriately. So we will get to that later, but in general, parathyroid disease is characterized by problems with calcium. If you've got a normal calcium level and it stayed normal over a long period of time, then you can be pretty sure your parathyroid glands are working. Now, they may be working really hard, but they are working. There's something going on. And for most people, they're working normally. If you've got again, normal diet, no issues with malabsorption, likely your parathyroid glands are just chugging along normally. But we will get to some of these cases where calcium level's off or it's sort of normal, but there's still a parathyroid issue. But we'll talk about that next time. The big thing that I just want to introduce is the difference between primary hyperparathyroidism and secondary hyperparathyroidism, because it's a key distinction, and we're going to go over it again and again and again because it is so confusing for a lot of people. So primary hyperparathyroidism is when what primary means there's a problem with the parathyroids. Secondary hyperparathyroidism means there's a problem, but it doesn't start with the parathyroids. It involves the parathyroids, but that's not where it started. There's something else causing the problem. So primary, it's the parathyroids. They're doing something wrong. Secondary, parathyroid glands are doing their job, but there's something going on, something that's not right. All right, so just keep that in mind. Primary, there's something wrong with the parathyroid glands. Secondary, there's something wrong and it involves the parathyroids, meaning they have to make too much hormone, but it's not originating with the parathyroid glands. Okay, very, very important to understand that. Okay, so let me see. Oh yes, and about labs. So just so everybody's on the same page here, calcium is often checked on annual labs. As I mentioned, the basic metabolic panel, the comprehensive metabolic panel. These other things I'm talking about are not. So a parathyroid hormone level is rarely checked. The only reason it's checked is if you have some suspicion of a problem. So if your calcium level is out of range, or if you've got some evidence that your parathyroid glands might be overactive. And if you think about what the parathyroid glands do, the main thing that I'd be talking about is significant bone loss without any other cause. So if you're a young person and you have no family history of osteoporosis, but now you've got osteoporosis and you're breaking bones, your doctor may order a parathyroid hormone level to see if that truly is normal. Maybe your calcium level is normal, but your parathyroid glands are just working overtime to keep that calcium in range, and that is causing the bone loss that you're seeing. So a lot of times we check the PTH if the calcium level is not normal, or if there's severe osteoporosis and we think, okay, maybe it's parathyroid hormone that's causing the bone breakdown. The other one, vitamin D, not checked routine. This varies a lot by location and by doctor. So it is not part of a lot of standard panels, but a lot of doctors do check it. And it does make sense to check it in certain situations, especially if you've got low calcium levels. And it would make sense to check calcium, vitamin D levels there. Also, if you're on supplementation, especially if you're on higher doses of supplementation, it makes sense to get a baseline and to follow your vitamin D levels while you're on supplementation rather than just taking it blindly, because it is very easy to check that inactive level. And so if you ask for it, you can check it, but it's not something your doctor would necessarily order unless your doctor orders it in everyone. And there are doctors out there that do that. Okay, so we'll discuss surgery issues later. So Barb asked, how often should you have blood work after surgery? I mean, I recommend going back to what I recommend for everyone, which is just annually. It's going to take a little bit of time. If you're cured after surgery, and that means that at about a month or two after surgery, you have normal labs. So when I do parathyroid surgery, I typically tell people to get labs done in 6 weeks, but it can be done 4 to 8 weeks or somewhere around there. If your labs look perfect at that point, then really you can go back to kind of annual lab checks. You don't need to really carefully follow it, because it's going to probably take a little bit of time for there to be any other issue, if there was any other issue. Most of the time you're cured with a single operation. But if you're not, if the disease does come back, it will typically either be present right there on the 6-week labs, or it will come in years later. It will come back years later. So if you have perfect labs at 6 weeks, that's great. If your labs aren't perfect at 6 weeks, you still may be cured. You still may be fine. We would just need to recheck it a couple of times, a little bit closer, like in a few months. And then once they're normal, you can go back to annual labs. So that's what I recommend. And that's typically what older adults are going to have done anyway. If you go to your doctor and you see your primary care doctor regularly, they get annual labs. And again, calcium's included in there. If you're taking vitamin D or you've got osteoporosis, then I also recommend checking that vitamin D level at least annually as well. You don't necessarily need to keep checking the PTH unless you had normal calcium levels with high PTH. Then I would probably check it just to make sure that's staying in range as well. Okay. And yeah, so when you have a problem with the parathyroid glands, again, this is not the most common thing with a parathyroid is a tumor, but it's not like what most people think of for tumors. So when I say someone has a tumor, usually you're thinking a mass, like a growth that you can either see or feel, and there's a risk of cancer. A lot of these things are different with parathyroids. So with parathyroids, when you get a parathyroid tumor, first, it's almost never cancerous. These things are pretty much always benign. And cancer presents much differently than benign parathyroid disease. So for nearly all of my patients, I can say, look, I know this is benign even before operating, and then once I see the tumor, I can guarantee it's benign even before we get the pathology report. But when I say, you've got a tumor, people think cancer. They also think mass or a growth. Well, technically, these parathyroid tumors are growths, but they're tiny. So if the gland is a grain of rice, the tumor may be the size of a raisin. It's not ever going to be palpable, especially at that size. You're not going to be able to feel it. And you may not see it on any scans. So these tumors are different than what most people think of when they think of tumors. It's not a growth. It's not cancer. I mean, it is a growth. It might not be visible on any scan. And we're not talking about cancer. But it takes a long time for these adenomas to grow. It takes a long time to see problems with parathyroids, because when you do get a tumor, it grows very, very slowly. So typically, most people have had it growing a few years before they even get to a doctor. And they may have had it growing for a few years even before their calcium levels started to go high, right? So you have to kind of have it for a little bit before you'll see any problems associated with it. So when I see people, when I operate on them, usually they've had it at least a few years, sometimes many years, before anybody's referred them to surgery. Okay. I think I got kind of the normal function. If you have any more questions about like the normal function of parathyroid glands, let me know. Post them here and I'll try to answer. But I think I covered the basics. That the function of the parathyroids, again, think about the thermostat. It's really important to think of them as the thermostat for calcium. Calcium drops too low or goes below normal, they make more hormone to bring the calcium up. If the calcium's too high, they sense that and they turn off the heat, which means make less hormone, which allows the calcium to drop down. Okay, very important to think about it that way. That will explain a lot of the pathology and pathophysiology once we get to that in future lectures. Okay. All right. And calcium, again, calcium is super important for so many things. That's the reason we have an organ, or 4 little organs to regulate it. It's because it's really important for the brain, for nervous system, for your blood, lots of different things, cell function. Okay, so if you have any questions, put them in there. I will try to answer all of these questions. So I'll go over any question. But if it's something about parathyroid function, that is I'm going to prioritize that. Okay, so let me see. So Sheila asks if this was related to Cushing syndrome, if hyperplasia is involved. Okay. So we will get to this is a little more complicated. We will get to this in later videos, but there are syndromes that involve multiple endocrine tumors, and that's what it's called. It's called multiple endocrine neoplasia. Neoplasia just means a tumor. So there are a couple of syndromes that are these rare genetic syndromes where you get endocrine tumors. In a couple of them, you can get parathyroid disease, and when you see these syndromes, MEN, like MEN1, when you see MEN1, you get hyperplasia of the parathyroid glands. And hyperplasia means all 4 glands get enlarged and overactive and cause a problem. They cause primary hyperparathyroidism. So if you've had other endocrine tumors and you have parathyroid disease and you've got enlargement of all 4 parathyroid glands, then there's a chance you have one of these syndromes, like MEN syndromes. That has to be verified with genetic testing, and that is a little more complicated, and which endocrine glands are actually involved gets a little more complicated. So we'll deal with that at a later date. But yes, there are conditions where you see multiple endocrine issues together. Okay. Okay, so Chris says, had blood work done 6 months after surgery and everything looks good except the kidney numbers are just below what they should be. Calcium PTH is perfect, scar is great, and vitamin D is 39. So a vitamin D of 39 is actually really good. I know there are people who recommend keeping the vitamin D higher. You can. The evidence for vitamin D is not great once you get to a certain level. So we do know that vitamin D is very bad for you when it's really low. And we know that increasing it from that really low level to a normal level, or even a low normal level, will relieve some of those issues. So for example, rickets, the things that we saw when you could see in children when their bones aren't, when they don't have enough vitamin D and calcium and their bones are kind of not developing properly. That's what can happen in sort of severe vitamin D deficiency. But you actually don't need much vitamin D to really correct that. So a normal vitamin D, what we say in our country now, is about 30 nanograms per mil. And some people, though, recommend much higher ranges. I typically don't, because I see a subset of patients who get high calcium levels from vitamin D supplementation. And it happens. And it's not that hard to really get too much vitamin D. So I tend to recommend to people that they take between 30 and 60, or that they take a moderate amount and keep their vitamin D level within 30 to 60. So I like a vitamin D of 39. It can go up a little bit, but unless you have a good reason to try to keep it higher than that, then I typically don't. And there are some conditions where it seems like a higher vitamin D level may be helpful. So there are people who do try to keep their vitamin D level higher, but again, you should have a reason for doing that, not just because you want to. It should really be because you're trying to treat a certain condition, and you have to monitor your vitamin D and calcium level very closely when you do that. Okay, about the kidney numbers. So I'm not sure what's going on with the kidneys. Actually, what we know from parathyroid disease is that typically you see improvement in kidney numbers after surgery on average. But again, this is an average, and this gets into the surgery talk, which is kind of talking about the expectations and outcomes from surgery. All of what we talk about is on average. We're looking at, a large population of patients getting this operation and what happens. And when you do look at their creatinine and their GFR, we on average see improvements in people who have some decline in function before the operation. They will see an improvement in function after the operation. But that is not true for everyone. If this has only been a once off with the kidney numbers kind of below where they were, then the first thing to do is really just check everything again, and make sure that they were accurate, and also check your supplements. I don't know if you're taking creatine, but when you do that, you can influence the creatinine number, which is what we typically that's how we estimate your kidney function, but it's not really accurate if you're getting a lot of creatine supplements. So again, recheck it. I'm not sure what the function is. Maybe another issue going on. Okay. Lisa asks, I heard it's a good idea to have a DEXA scan done once the diagnosis is made. Should this be ordered by the PCP, or can we get the order from you if you're the surgeon? PCPs don't always have the knowledge. So I think it is a good idea to get a DEXA scan for a lot of people with this. The exception would be really young people, because the odds that you'll actually see anything on the DEXA scan are pretty low unless there's some other reason. Again, you have to look at the whole clinical picture. But for a lot of people getting diagnosed with parathyroid disease, a DEXA scan makes sense. Anybody over the age of 40 with parathyroid disease, I would do a DEXA scan. And I do occasionally order it for people. Usually they have it done by their primary care doctor. If there is a big, pushback from the PCP, then I can order it. But usually, they will do it, and insurance covers it. It is, sometimes there's pushback from insurance companies too, but it is indicated when you know that you have primary hyperparathyroidism, especially if it's going to change your management. And one example would be, if it's not going to change your management at all. So if you say, I'm not going to go on osteoporosis medications no matter what it shows, then there isn't a huge benefit to checking the DEXA scan. The only benefit would be to kind of prove to your doctors that you have some bone loss from parathyroid disease. But again, that's not really entirely necessary. Insurance companies pay for parathyroid surgery if you have the diagnosis. You don't need to prove a whole lot of things before getting it. But again, I do think a DEXA is good for most patients. I do order it sometimes, but it's not necessary for everyone. Okay. Giovanna says, my PTH was tested after diagnosis of osteopenia and osteoporosis and before treatment with Prolia. Labs were 997. I'm not sure what that's referring to. If the calcium was 9.9 or PTH. So whenever interpreting like PTH or calcium, you have to have both numbers. If your PTH level was 997, that would be incredibly high. And so I would want to know what the rest of the story was. So whenever tells me, so this gets to an important point actually. I have a lot of patients come to me and give me their PTH level and ask if it's a problem. So they'll say, Dr. Boone, I've got a PTH of 100. Does that mean I have parathyroid disease? Well, the answer is maybe, but I don't know, because I don't know what your other labs are. And as I mentioned before, PTH, parathyroid glands, they only care about calcium. That's it. That's all they care about. So your calcium level is absolutely necessary to know whether that PTH is appropriate or not, know what the parathyroid glands are doing. If you told me that your calcium level was 8.0 milligrams per deciliter, that's really low. And I would expect your parathyroid glands to make more hormone, meaning raise the PTH level. So if you've got a calcium of 8.0 and a PTH of 100, that's actually a very appropriate response from your parathyroid glands. It is secondary hyperparathyroidism, but remember what I said earlier, secondary indicates that the problem is not with the parathyroid glands, it's with something else. There's a problem that's causing your calcium level to be low, which is then causing your PTH to be high. But if you told me, oh, my calcium is actually 11 and I have a PTH of 100, then that indicates primary hyperparathyroidism, because at 11, I know your parathyroid glands should be turning off. They should just be stopping any production of new PTH because the calcium is already too high. So if you tell me your calcium's 11, 12 with a PTH of 100, that's primary hyperparathyroidism. You tell me the calcium level's 8, okay, that's your parathyroid glands actually doing what they should. So I'm not sure what the 997 is. If that is the PTH, that would be an exceptionally high PTH. And usually we don't even see that with primary. We often see it with secondary, things like renal failure. So, but I'm not exactly sure what it's referring to. So Giovanna, I would need more information to be able to tell you anything. Okay. Okay, so Allison says, my labs have normalized since I had surgery back in 2023, but recently my vitamin D jumped from 35 to 55. Okay. The test was taken after I returned from India, where I was for 5 weeks, and you attributed it to being in India. It's interesting. I don't know. I mean, vitamin D levels will rise with certain things. Usually they rise like that when you take supplements. But if you weren't taking any supplements and it just went from 35 to 55, it could also be from sunlight exposure. If you weren't getting a lot of sunlight exposure and then you went to India and you were on the beach every day, or in a bikini every day and getting lots of vitamin D, typically the body will kind of you can't get too much vitamin D from the sun. But vitamin D its stimulation is dependent on getting sunlight, and that's how most people will get their vitamin D if they're not taking supplements. So theoretically, you could have gotten more sunlight. I don't think that India is putting a lot of vitamin D in things, and that's why. So I would say it's probably sunlight. Okay. Jenny says, why do you refer to them as both adenoma and a tumor? Oh, this is interesting. So you'll hear me do this. I talk about parathyroid adenomas, and then I talk about parathyroid tumors, and I'm talking about the exact same thing. So a tumor is just a growth, an abnormal growth in the body. It doesn't mean benign or cancerous. You can have cancerous tumors, you can have benign tumors. So tumor just means a growth. An adenoma is a little more specific. It's the type of tumor. So all adenomas are tumors, but not all tumors are adenomas. An adenoma is a benign type of tumor in the parathyroid. Tumor is just kind of a general term. So I say it sometimes just easier to say and just kind of more what people understand. But know that when I say adenoma, I'm talking about a benign tumor. Okay. Rachel Kinney asks, this is a really good question. Why would an 8.8 or 8.9 calcium level with mid-normal PTH not be considered a good calcium level? So this is a great question. It actually could be a good calcium level, especially if the PTH level is on the lower end of normal. So if you had a calcium level of 8.9 and a PTH of 25 picograms per mil, and you were not taking lots of calcium to achieve that, then I would say, okay, your parathyroid glands seem to like this level. They're not responding by making a ton of hormone. This may be within your normal range. It is uncommon. It is very uncommon to see an 8.9 be a normal range, but it happens. Every once in a while, I do have somebody where they just seem to live at 8.8 or 8.9, and that's fine. The issue, though, is that in a lot of these cases, if the calcium is 8.8, the PTH won't exactly be normal. It will be on the high end of normal. It'll be somewhere like 60 or 70, and your lab may call that normal, but it's not exactly normal. It's on the higher end, and it indicates that the parathyroid glands are trying a little bit harder to get that calcium level up. But again, low normal PTH, and you're not taking calcium and it's 8.8, tells me that the parathyroid glands are okay with that. Another scenario when you might see an 8.8 with a normal PTH would be in hypoparathyroidism, but you would know that because you would be taking a ton of calcium to maintain that 8.8. But yeah, there are people who walk around with calcium levels in the low 9s. I do see them. I don't normally see normals that are consistently and persistently in the 8s that often, but some people do have calcium levels in the low 9s. Again, most of the time, people have calcium levels in the mid to high 9s, but there is some individual variation. And there are even people who walk around with calcium levels that are in the low 10s, and that's normal for them. Again, there are these weird situations do exist. Okay. Carol asks, do the parathyroid glands function include regulating calcium in urine? Is an abnormal high urine calcium an indicator of parathyroid disease or hyperparathyroidism? So this is a great question as well, because patients often get sent to me for high urine calcium, and they get sent because the doctor believes strongly that high urine calcium indicates parathyroid disease. The answer is not really. So parathyroid glands are not regulating the calcium in the urine, right? Remember, the parathyroid glands, they sit in your neck and they have blood flow going through them, and that's how they sense the calcium level. They sense calcium. That's it, blood calcium. They don't sense urine calcium. Now, they do somewhat control urine calcium, right? Because parathyroid hormone will go to the kidneys and stop the kidneys from releasing so much calcium into the urine. So they'll hold on to more calcium, again, to keep the blood calcium level up. And then if there's not as much PTH, then you may have more calcium going into the urine. So in some sense, the parathyroid glands are affecting urine calcium, but they are not directly regulating it. They're not sensing the urine calcium and trying to regulate it. They're really just trying to regulate blood calcium. Okay. So what happens? Why would the urine calcium be high? There are multiple reasons why urine calcium can be high. The first one, and the one that most doctors are thinking of, I think, when they send patients to me, is if you have a high blood calcium, then your kidneys just have to process that. And so they process it, and a lot of it goes into the urine, and you end up with a high urine calcium. So it's a direct effect. Your blood calcium's high, it's getting filtered by the kidneys, and they're filtering out just, a certain amount, and it goes into the urine and it's high. It just gets getting dumped into the urine. Okay. That's one reason. And that's why with primary hyperparathyroidism, you will see high urine calcium. Just to confuse you a little bit, think about what I said about PTH earlier. Parathyroid hormone stops the kidneys from releasing too much urine into releasing too much calcium into the urine, right? They stops that calcium going into the urine, okay? But when you have a parathyroid tumor and you have high PTH, you end up with high urine calcium. How is that happening? Well, it's happening because the blood calcium overcomes it. The blood calcium is high, so there's just a lot of calcium going through the kidneys, and it's spilling into the urine. That's how you get that high urine calcium. But there are other causes for high urine calcium, and one that I see not that infrequently now is renal calcium leak, where the underlying problem simply is too much calcium in the urine. That is the problem. The kidneys are otherwise functioning normal. Their creatinine's fine. They're doing their job. They're filtering out the toxins, etc. But they're just releasing too much calcium into the urine. That in itself will cause problems because it's a loss of calcium that your body doesn't want. So your blood calcium level may actually drop if you lose too much calcium in your urine. So whenever I see somebody and they're sent to me and they have high urine calcium, the first thing that I do, again, is look at their blood calcium. If their blood calcium is high, then I know the urine calcium is high because it's spilling into the urine. The high blood calcium is just spilling into the urine. But if their blood calcium level is low, then I know, you know what? Their body wants to hold on to this calcium, but it can't. The kidneys are the source of the problem with the calcium. It's called renal calcium leak. That's what's happening. The kidneys are just releasing too much calcium. That's dropping the blood calcium level. And what will happen then is that the parathyroid glands, again, they sense blood calcium, not urine calcium, not bone calcium, not anything else. They just sense blood calcium. They sense that blood calcium that's low, and they make more hormone. So you'll see the calcium level be low, PTH rising, high urine calcium. The problem is you're losing calcium in your urine, and your parathyroid glands are having to say, no, I want more calcium. So they're making more and more PTH to try to get it up, and then it just keeps spilling into the urine. And the problem there is a separate issue. We'll get to that because that's an advanced topic because it confuses a lot of doctors. And I have to I was just doing like a information sheet for doctors about that because it's not something that they see all the time. Okay. Let's see. Dina says, I've had 2 unsuccessful surgeries. All the tests show where the adenoma is, and you had a PET scan to clarify it. The doctor wanted to do an FHH, which was negative. I'm assuming they did genetic testing. They did not offer to try another surgery. They recommended ethanol ablation. I've done lots of research on this and feel it's not a cure. They say my case is complicated. So it is, and so there can be multiple things that are true here. It is more complicated, especially when you've had 2 prior surgeries. Things do get more complicated. However, I have done 3rd and 4th operations on patients who've had other parathyroid operations and weren't cured. It's a matter of figuring out where you think it is, and it looks like you have a target, and then deciding when to do it. And sometimes you have to wait a little bit longer for things to heal and for things to get a little bit easier to go back in. So reoperations are very complex and they require a talk of their own, but it does not sound like you are not curable. This scenario happens a lot. Where somebody's had 1 or 2 parathyroid operations and they haven't been cured and the tumor is seen on scan. Your operation is definitely more complex than others, but it's not impossible. Ethanol ablation, I mean, it can work, but it's temporary in most cases. So I wouldn't really recommend it. It can cause scarring, which makes the operation a little more difficult. And the problem is that it works, but very temporarily. So I wouldn't do the ethanol ablation. I do think that another operation is in your future. And so I think that's probably where you're headed. Okay. She asked about the adenoma and tumor. I think I answered that. Why it's an adenoma. It's the same thing. Okay. Rachel says post-op calcium 8.8, PTH 43, which is good. That's a good PTH. That's a good thing. And it says 8.9, 58. So that tells me, okay, the parathyroid glands are trying to do a little bit more. Definitely taking calcium and dietary calcium. It kind of matters how much you're taking. So if you are taking massive amounts of calcium to maintain that, then I would say, first, the 58 PTH tells me that your parathyroid glands don't exactly think that's normal. They are trying to get it up. But I wonder what is happening there. If you're on lots of calcium, is there an issue with absorption? There are a lot of things that I have to consider that I do consider in cases like this. So, and I go through it kind of stepwise. So, how much are you taking? Are there any issues with absorption? So I see people in the office and I always start asking about their bowel movements and their dietary calcium and what they're eating, when they take their supplements. You have to get all of this information to see, are you absorbing the calcium? The next thing to do is check some of the urinary calcium levels because you could be peeing it out. And sometimes I do see this, people post-op where, you do the operation, they're cured, they look great, but then the calcium level is kind of on the low end and PTH is rising and it's not really clear. And you check their urinary calcium and it's still high, even though the blood calcium level is low. And that's a separate issue from primary hyperparathyroidism. It's secondary hyperparathyroidism caused by renal calcium leak. So I would wonder, especially the 8.9 to 58 tells me that your parathyroid glands are working a little bit harder, and it might be good to try to get the calcium level up a little bit. Okay. Faye. Let me see. It says, it's like you're immune to understanding paracrine and autocrine vitamin D. Understood your parathyroid renal feedback focus, the fishbowl, but it doesn't take much to stick your head out and understand the research paradigms you're aligned with. Focus is a different system. It's endocrine, missing vital connections to fuller understanding that systemic 125 release is not what most cells rely on. Many cross-talking between this. Okay, so the active vitamin D, I mean, the active vitamin D is the one that's working on the intestines, which is related to calcium absorption. And it does have a very fast half-life, that active vitamin D. I'm not really sticking my head into the sand. There are, yes, there are a lot of issues with vitamin D and things that vitamin D does that are not related to calcium metabolism. And that is where we may see those benefits to increased levels. We don't see the increased levels benefiting things like bone health. So if you're trying to get your vitamin D to 60 to help with your bones, it may not be doing that. But there are immune effects from vitamin D. I actually wrote a few articles, like blog posts, on vitamin D and its role. And so I can link to those. Vitamin D is complicated. It's become kind of a really popular vitamin, and it's true that it is important. It's true that it does a lot, and it probably does more than we think, even immune wise. But I'm not sure what you mean. I am immune to understanding this. Anyway, but we'll get to vitamin D later. I do like talking about vitamin D, and it's complicated. For the most part, though, I think for most people, keeping their vitamin D level in a normal range, like 30 to 60, is probably the best advice. If you do have a reason to keep it higher, then you can do that. But again, it requires closer monitoring. Okay. All right, so let me see. So Lisa asks, do you have to limit calcium intake prior to blood draws? This is good. So limiting calcium intake. So it's interesting. So I've tried looking this up, and it does seem that if you do take a bolus of calcium, so if you take a calcium supplementation, your blood calcium level will rise slightly temporarily for a couple of hours after taking the supplement. It probably isn't clinically significant, but if you're in a weird case and we're trying to figure stuff out and we want to make sure you're cured or whatever and you've had surgery, then just don't take it within 4 hours of getting your blood drawn. So I tell people, if you're concerned about it, just get them done in the morning before you take your calcium. That will give us kind of a good baseline. And so that's what I would recommend doing. But drinking milk before you get your labs drawn, probably not going to really have much of an effect unless you were drinking an entire gallon, which I wouldn't recommend for other reasons. Okay. Okay, and Rachel's taking over 1,800 to 2,000. So I think digestion improved a lot since surgery. So I think in your case, it's a little more complicated, and I would want to look more into that urine calcium. You said you're going to do the urine calcium. That's the right approach, and because it does seem like you're having a hard time getting your calcium level up, even with a significant amount of calcium. I'd want to review your calcium and see what form you're taking and make sure you're actually getting the 1,800 that you think you're getting. I think I did a Facebook Live, which has since been deleted, on this before, but it's very common to kind of misread the labels and not really be getting what you think you're getting. But if you are definitely getting 1800 in supplementation, then it seems like that needs a little bit further investigation. Okay. Lisa says, should labs be drawn at a certain time of day, fasting or non-fasting, and does black coffee affect PTH? Okay, so this is really interesting. So, it doesn't really matter with PTH what time of the day you draw them. A lot of times I'll tell people, again, get them done in the morning just because that's kind of easiest. You don't need to be fasting. It's not going to affect the calcium and the PTH. As long as you're not getting, again, that gallon of milk, but you don't have to fast. Black coffee affecting PTH. A lot of the things we take can affect labs in some way, but they're not significant enough to matter. And this is even true for things that we think are kind of dogma. So I'm going to blow your mind here. When you get lipid testing done, when you get like cholesterol checked, you have to be fasting. The lab makes a big deal out of it. This is the one where they really make a big deal out of it. You have to be fasting. So I finally looked it up and said, do you really need to fast? And in most cases, if you're doing it as a screening test and you don't have any concern about your cholesterol levels and your lipid levels, if you're non-fasting, there may be a 2% change in your levels, which for most people is not significant at all. So most people probably don't need to fast before they get their lipid levels checked now, or their lipid panel. If you do that, do not tell your doctor I told you to do that. But I'm just saying that for a lot of things that kind of can affect things, it's a very minor effect. So does black coffee affect PTH? No, I don't think so. Don't worry about your diet. Just get the labs strong. Now, there are a couple things that do matter, and one of them is biotin. Biotin can affect, depending on how the lab does it, it can cause a falsely, low or elevated PTH level. Again, depending on what it does. Not all labs do it this way, and so it might not be affected at all with biotin. But I do recommend stopping your biotin 5 days ahead, just in case. Okay. Eli says, I had 2 glands removed, was considered enlarged, but not an adenoma or hyperplasia. What does that mean? It doesn't mean much. So what does it mean? This is going to get into surgery and pathology results. And I think I haven't actually specifically talked about pathology results on these videos, and I need to, because this is a common question. What exactly did I have removed? The doctor told me it was abnormal, but was it an adenoma or hyperplasia? And the honest answer is, I don't know. And the pathology report can't tell us that, and the surgeon can't tell us that either, because sometimes they look exactly the same. So you have to make a decision sometimes when you're calling things, saying, oh, okay, well, I see one huge gland and I see 3 tiny ones. Most likely that's an adenoma. If I see 2, beans in there, kidney bean size things, and 2 tiny glands, okay, that looks like 2 adenomas. But occasionally hyperplasia will not present as 4 enlarged glands. It will present as 1 or 2 enlarged glands, which the others look normal, but then over time the others grow. So 2 abnormal glands that are not called adenomas, tricky. Could be that you just had 2 adenomas. Could be that you have hyperplasia and it's going to develop that. But your surgeon called them abnormal because they weren't normal, but your surgeon wasn't confident or didn't know. I mean, this happens with me too, is I have to make a decision. Your surgeon didn't make the decision, just said, yeah, they're abnormal, but I wouldn't call this hyperplasia an adenoma. Sometimes pathology can help, but very rarely. Most of the time, those glands look exactly the same under the microscope, adenomas and hyperplasia. So it often doesn't help. Okay. Are there alternatives for people who can't dissolve the dissolvable stitches? So, everyone can dissolve the so the dissolvable stitches will they dissolve on their own, right? It's not that you can't dissolve them. I don't know anyone who truly can't dissolve dissolvable stitches. But the thing is, even if they take longer to dissolve or they don't dissolve, that's okay. The problem is if you have, so patients often think that they can't dissolve stitches because they have a spitting stitch. And this occurs with certain operations more often than the neck. Sometimes like there are certain operations where you more frequently get these types of things where you get the stitch kind of not dissolving and there's maybe a little bit of infection around it and then it kind of spits, like it comes out. That happens usually because there's a little bit of inflammation around it, infection around it. The body then creates a seal around it, doesn't heal, and eventually it kind of expels the whole thing. It's not that you are incapable of dissolving stitches. It's that there was inflammation or infection around that individual stitch, which caused your body to reject it. That happens more often with things like breast surgery, inguinal hernias, certain operations that tend to do that. It's pretty rare in the neck. So all the stitches I use are inside. And again, if they take longer to dissolve, it doesn't really matter because they could just not dissolve. They don't have to dissolve, but they do break down over time. And that's what sort of means by dissolvable. They just break down over time. Okay. Other people said, thank you. Okay, Rachel, so you have pure encapsulations. Good. So it is 150 per capsule. Well, mostly in your diet. So this is really tricky. Rachel, when people calculate it just from their diet, it's very hard to know exactly what they're getting because you have to, I'm sure if you're calculating it, you have to look at oxalates as well. So if you're getting spinach in there at all, then you're getting a high amount of oxalate, which will bind to the calcium and won't allow you to absorb the calcium that's in it. So spinach, for example, I hate spinach because it's got high oxalates. People, it's got lots of calcium, but you're not absorbing any of it because of the high oxalates. So you have to kind of look at that. You have to look at, what else you're getting in your diet. And sometimes it's just not as accurate. And I see this with people, when they calculate in their diet, it seems like they should be getting enough. But then if we give that to them in supplements, their levels improve. And so for whatever reason, the dietary calcium wasn't doing it. So I would suggest increasing the dietary. Okay, so you only do the highest start. Yeah, that's good. It does look like you need more supplements at this time, but I would also want to see that urine calcium to make sure you're not losing it in the urine. But then this is kind of it's a trickier case, but it looks like it's a form of secondary. But we would need to investigate more. Okay, well, I gotta go. I have to get to the gym. But thank you for everyone who joined me tonight. We will be doing the third Tuesday of every month. And next month, we are gonna start to get into the actual what can go wrong with parathyroid disease. Okay, I will see everybody here next month then. Take care.